Good afternoon. My name is Professor Gary Connett. I am a consultant in respiratory paediatrics and I work in the UK at the University Hospital Southampton. I'm going to talk to you today about two particularly important aspects of asthma treatment, which I think are worth thinking about and reflecting on in relation to our practice. But when it comes to thinking about asthma and talking about it from the UK, in some ways I could be something of a fake. Not sure I'm that well qualified to be an expert. And this is the reason why. This is a slide showing some data for the tip of the iceberg for asthma outcomes. These are the data for mortality rates in two age groups, 10 to 14 and 15 to 19 years of age, in the UK, shown in green, that bar at the bottom of the diagram, compared to other European countries. And as you can see, we're not doing very well. The mortality figures in the UK appear to be significantly higher compared to other European countries. So why is this? Well, it's not obviously related to asthma care costs. This picture here shows you that the UK, alongside Germany, spend more on asthma care, both in paediatrics and in adults, compared to most other European countries. So probably the reasons why are something to do with the way that care is delivered and the types of drugs that are used to treat patients in the UK. So I want to focus on particular two aspects of care which perhaps could be changed to try to improve outcomes. The first is to do with an over-reliance on beta-2 agonists, in particular short-acting beta-2 agonists, and I'll show you some data to suggest that we are an outlier with respect to the use of short-acting beta-2 agonists for poorly controlled asthma. The second is to do with the underuse of effective interventions to prevent asthma attacks. And again, I'll show you some data that suggests that perhaps we're not making the best choices for the majority of our patients when it comes to how we manage asthma on a day-to-day basis to try to prevent acute asthma attacks. So if you think about this in reverse, what works and why? Perhaps what will work better would be less reliance on beta-2 agonists and more effective interventions to prevent asthma attacks beyond what we're currently doing most commonly at the moment. So let's look at some data. This is the Sabina study. It was published in 2020. And what we can see here is a comparison of the relative use of salbutamol for mild and moderate asthma in 5 different European countries. Above my head here is the UK, and for each country we've got mild asthma and moderate and severe asthma. And within each of those two groups we've got 4 bars. The blue one represents patients using 0 to 2 canisters of short-acting beta agonist a year. The orange is 3 to 6 canisters of short-acting beta agonist. The grey is 7 to 12 canisters, and the yellow is more than 13. And what I think you might be able to appreciate is that when we look at the UK data for the moderate to severe asthmatics on the far right-hand side here, what you can see is that there are more patients using more SABA than other countries in Europe. And if we break that data down further, it's even more interesting. So what we've got here now is the UK data, and it's broken down according to BTS steps. Step 1 is the first step of asthma treatment with, as required, beta-2 agonist used by itself, and then step 2, step 3, step 4, step 5 refer to increasing doses of asthma medication with low dose, medium dose, higher doses, LABAs, LTR treatments added into the mix to try to control symptoms. And what we can see here is that for each step, the data has been broken down into patients who are using low amounts of SABA, less than 3 inhalers per year, and a higher doses of SABA more than or equal to 3 SABA inhalers a year. And what's really interesting, I think, is that across this whole range of asthma severity, as suggested by treatment need, the risk of exacerbation, the risk of asthma attacks, as shown on the y-axis, relates to the number of SABA uses each year. So patients who are using more SABA are at increased risk of having asthma attacks, irrespective of the underlying severity of their asthma as categorized by BTS steps of treatment. So what is going on here? Well, there's 2 possibilities. It could be that high uses of salbutamol is just an indicator, a marker of poor asthma control, or it could be a confounder for some other underlying reason. Or it could even be that large amounts of salbutamol might actually be causing more acute asthma to occur. Or it could be both. I think irrespective of which of these explanations is correct, and it's quite a long talk to go into more detail about that, you would probably agree with me that putting in place measures to decrease salbutamol use is probably a good idea to try to limit the extent to which salbutamol is being used and try to negate that association with a risk factor for more severe asthma attacks. So we looked at this from the other end of the spectrum for patients who are being discharged after acute asthma. And in the UK, it's common practice until recently in most hospitals to give salbutamol according to a fixed dose weaning regime during the recovery from acute asthma. So what that means, for example, the most commonly used one, as we were practicing in Southampton until recently, is to give 10 puffs of salbutamol through an MDI and spacer for the first day of admission every 4 hours. On the second day, we advise that the dose is reduced down to 5 puffs 4 hourly, and on the third day, 2 puffs 4 hourly. But what we did instead was we worked together with our emergency department, and we got patients involved and families of children who've had acute asthma attacks, and developed an action plan, a discharge plan that uses salbutamol on an as required basis. And this was published in the Archives of Diseases in Childhood earlier this year, if you want to read about it in more detail. The discharge plan that we give is as shown here. We provide some simple explanation about what wheeze is and how to go about treating it, how to use this care plan, this discharge plan. We advise assessing children every 4 hours, giving 2 puffs of salbutamol initially, and then reassessing and giving further doses only if needed, with some clear safety netting around maximum doses, expectations of recovery, and when to seek help if things aren't improving. The second page of this sheet shows some advice about how to use an inhaler with a spacer. There are some hyperlinks to whether you want to be using a face mask in the younger children under the age of 3 typically, or a mouthpiece for a spacer in the older age group. And we ask families to record the amount of salbutamol that's given in a treatment log, which gets used in about a third of patients when we looked at this for the first 100 children that used this discharge plan. So what happened to salbutamol usage? Well, this slide shows the data comparing what would have happened if families had followed the 10, 5 and 2 doses 4 hourly on day 1, 2 and 3 and compared it with the actual doses that families reported as giving on those days when using our new treatment plan, giving salbutamol as needed. And what you can see here quite clearly is that families used far less salbutamol than we would have anticipated. And that's about a third of the doses that would have been given had they followed a strict fixed dose weaning plan. When we looked at the readmission rates, the number of children coming back into hospital for the first week after being discharged, the numbers were no different, and if anything slightly lower than those which occurred in the 6-month period prior to us first introducing this plan. What we've done since then is we've actually been using increasing numbers of patients treatment with a SMART regime using the Symbicort turbohaler without the need for a salbutamol inhaler. The Spiromex Duoresp can also be used in the same way, containing both eformoterol and budesonide, an inhaled steroid. And when these patients are discharged having had burst treatment with inhaled salbutamol and Atrovent, they go back to using their Symbicort turbohaler or Duoresp inhaler without further doses of salbutamol during recovery after hospital discharge. And we find this a very safe and effective way of managing patients during the recovery period. Although in practice, I have to say that children who are now on MART regimes are much more stable than those we've seen historically, and the numbers coming into hospital on a MART regime is very small. We do have a small number of children who can't use dry powder devices. We prefer dry powder because of the environmental impact of aerosols on greenhouse gases and environmental issues, the contribution to global warming from medical uses of aerosols. But if we do have to use an MDI, we do have a MART regime for that Symbicort combination inhaler using a spacer device as well for those patients. So moving on, the second point I want to get to is the underuse of effective interventions to prevent asthma attacks. So this slide here you might be familiar with. It's taken from the current, soon to be succeeded, guidelines which we have in the UK, the BTS sign guidelines from our British Thoracic Society in particular about how to manage asthma in childhood. And it's a similar type of approach in adults and children. Essentially, what is advised is regular prevention treatment with inhaled corticosteroids in low dose in children with chronic asthma, and then a gradual escalation in treatment if symptoms are poorly controlled and if asthma attacks continue despite that first-line prevention treatment. And what typically is advised is adding in a long-acting beta agonist or a leukotriene receptor antagonist in younger children under 5, and then increasing the doses of inhaled steroids if that's not working prior to hospital referral for more specialist attention. So let's look at the evidence base that underpins this. The best place, I think, to go to for looking at the meta-analyses of randomized controlled trial data to underpin good practice is the Cochrane reviews. It's freely available to anybody to look at in the public domain, and it provides us a meta-analysis of randomized controlled trial data to answer important questions about best practice in relation to the use of medication. So what about the addition of a long-acting beta-2 agonist to inhaled corticosteroids for chronic asthma management as a fixed-dose combination treatment? So that's, for example, Seretide or Symbicort, dosed in the morning and dosed in the evening. Well, there are 39 randomized controlled trials in paediatric practice which have attempted to answer that question, and the Cochrane meta-analysis conclusions are fairly unequivocal in relation to what they show. This is their statements. In children with persistent asthma, the combination of LABA and inhaled corticosteroids does not reduce the risks of exacerbations compared to using inhaled corticosteroids alone. And furthermore, they went on to say the trend towards increased risk of hospital admission with LABA, irrespective of dose of inhaled corticosteroids, is a matter of concern and requires further monitoring. So, if anything, there was a slight signal suggesting the opposite, which they were concerned about. Now, this is perhaps surprising for many people when they hear this and they read about it. And there are several reasons why they might not think that this is the case. And one of them is when you look at the adult data. This is the Cochrane review conclusions in relation to the randomized controlled trials, which have done the same thing, adding in a LABA to inhaled corticosteroids in adults with chronic asthma. And the conclusions are quite different. What they say here is that in adults who are symptomatic on a low to high dose of inhaled steroids, Adding in reduces exacerbations and the need for oral steroids. So this is a very important message. And what it tells us is that children are not just mini adults. The evidence in children is different to adults. The drugs are working in different ways for important reasons. And so we need to make different considerations about what is best practice for our children under our care compared to what adult doctors would advise for their patients. But if you look on the internet, it's not that straightforward and you still get confusing messages. This paper came out just last year in the European Respiratory Journal. It was by colleagues of mine in the UK. It was the Einstein Collaborative Group, and they wanted to try and answer the question, what's the best step-up treatment for children with uncontrolled asthma on inhaled corticosteroids? And they did some work on this to try and answer this question. Their conclusion was that uncontrolled children and adolescents on low doses of inhaled steroids should be recommended to change to increasing the dose and adding in a LABA to reduce the risk of exacerbations and improve lung function. So why did they say this, and how did they get to this point when Cochrane reviews suggest otherwise? And the devil is always in the detail here, and the important word in that title is network. What they did was a network meta-analysis, and that's not straightforward and not the same as a head-to-head meta-analysis. What you have in a network meta-analysis is so-called common comparators. So for example, if we look at inhaled corticosteroids at the top there, and inhaled corticosteroids in low dose compared to low dose plus LABA, you see that thick green line coming down from the top. The data to look at how those two drug options perform does not just rely on the data between those studies comparing those two treatments. It also takes into account common comparators. For example, studies which have looked at inhaled steroids in a low dose and LABA and inhaled steroids in a high dose, and studies which have then also compared inhaled steroids in a high dose with inhaled steroids in a low dose. So it's got some indirect comparisons going on. And what this gives you at the end of the day is a ranking of preferences for treatment. And the preferences and the ranking is a result of the network meta-analysis, but it isn't necessarily good evidence that any one treatment is significantly better than another. And that's commonly misunderstood, unfortunately. When you look at a proper meta-analysis, and that is what these authors also did in their work, when you compare inhaled corticosteroids in low, medium or high dose with inhaled steroids with a LABA in low, medium or high doses, consistent with the results of the Cochrane review, there's no significant benefit from any of those options compared to inhaled steroids alone. So, an important lesson, an important consideration about how these drugs might best be used. Let's just think about the inhaled steroid dose now and look at the evidence in relation to that. So again, Cochrane has got a lot of randomized controlled data to answer the question, is there any benefit of increasing the dose of inhaled steroids to a patient already on treatment to improve their asthma control? Well, studies looking at beclomethasone dipropionate, BDP, beclomethasone becotide, 15 randomized controlled trials, they conclude that they have no effect on acute asthma, increasing the dose to a higher dose to a lower dose. No obvious decrease in asthma attacks by increasing the inhaled steroids. Similarly, with fluticasone, 51 randomized controlled trials come to the same conclusion, no effects of increasing the inhaled steroids to reduce asthma attacks. And for budesonide, there are 24 randomized controlled trials, and just one of those showed a benefit of 800 versus 200 micrograms a day in reducing asthma attacks, but 23 other studies were negative. That's the data. I think that's a lot of data. And it comes down to, what do we now do when we have the patient in front of us? The child who's been admitted to hospital with an acute asthma attack, how are we going to treat them going forward? How are we going to change their medication to improve their outcome? If we are practicing evidence-based medicine, I would argue there is very good evidence that adding in a long-acting beta-2 agonist or increasing the inhaled steroid dose is unlikely to reduce the risk of further asthma attacks. So what can we do instead? What other treatment options do we have to consider? Well, I think what we are probably underusing in the UK is a MART regime, maintenance and reliever treatment with a combination inhaler without the need for a SABA to control asthma on a day-to-day basis. This is not a new idea. The first studies that were done were back in 2007. This is the COMPASS, get that wrong every time, COMPASS study. And the COMPASS study was comparing 3 different interventions, over 1,000 patients in each of these groups. In the purple bar, you've got salmeterol and fluticasone given twice daily, and salbutamol, a short-acting beta-2 agonist, given as needed for relief of symptoms. In the orange bar, you've got budesonide and formoterol given as a fixed-dose combination twice daily, and similarly using a short-acting beta agonist, probably Bricanyl, as required to treat symptoms. And in the blue bar, you've got the same combination inhaler, albeit in a lower dosage, budesonide and formoterol, given twice daily, but for relief of symptoms, despite that medication, you use the same inhaler to relieve symptoms and give an inhaled steroid dose at the same time. The resulting dose of steroid tends to be less than just using a fixed dose combination overall, and the efficacy you can see there is that there's a significant reduction in asthma attacks, exacerbations, emergency room department treatment, the need for oral steroids, comparing the MART regime to fixed dose regimes using either fluticasone or budesonide. So this is good evidence, I think, and there are 16 other randomized controlled trials which have compared MART regimes with most other asthma interventions you care to think of, and consistently what they show is that MART results in fewer asthma attacks. So I think that's enough to inform our local practice, and I'm hoping that that will also be translated similarly to what's recommended at a national level in the UK. Here is our local Wessex adult guidelines. This is the adolescent and asthma side of it from 12 and above. This is paediatric practice for 12 to 18 essentially. And what we're saying here is don't use salbutamol. Use a Symbicort turbohaler. Ideally, use that as fixed dose combination treatment and use it PRN in addition for breakthrough symptoms using a MART regime. If the low dose Symbicort turbohaler isn't working, we tend to use the higher dose, the 206, and we also then have the option of using a Duo-Res Spiramix dry powder device as well. The small number of children in this age group who can't use a dry powder device can use the Symbicort MDI. For children who have mild symptoms which are intermittent, we are recommending the Symbicort turbohaler. The 200/6 is licensed for use in this way in the UK from 12 and above, and so we recommend this, and we try to avoid giving salbutamol to this age group. What about the 6 to 11-year-olds? Well, the evidence base here is not as good. There is one study, again, it's not a new study, it's from 2006. It has about a tenth, 100 children in each of these treatment arms. And what we've got here is a comparison between a MART regime using the Symbicort turbohaler, the 106, one dose once a day. That's the solid line we can see on that graph. The next line up, the dotted line, is a fixed dose of budesonide given twice daily with a short-acting beta agonist being used PRN. And above that, we've got the larger dotted line, a fixed dose combination treatment using budesonide in formoterol, but again with a short-acting beta agonist being used as required for symptoms. And you can see curiously that the fixed dose combination treatment is doing worse than the fixed dose of steroid alone, which is consistent with what the Cochrane meta-analysis was suggesting, a signal that perhaps there is an increased risk from that approach to treatment. So, some evidence, and in that same paper, we've also got some other outcomes here, such as exacerbations, peak flow falls, extra treatment needs and hospitalization. And you can see that on each of those outcome measures, the SMART treatment is doing very well compared to those other approaches to treatment. So we've taken this into account in relation to our own guidelines to try to impact on asthma attacks. And this is what we now have locally. And again, this is hopefully going to become national in the near future in the UK for treating asthma in the 6 to 11 year age group. Our first line treatments is still to give low dose inhaled corticosteroids. We encourage the use of dry powder devices. They can, with proper training, be used by the vast majority of children in this age group down to 6, using either the turbohaler or the AccuHaler for regular inhaled steroids. For the small number of patients who can't do that, we can use the MDI inhaled steroids instead. For relief medication, we don't have clear guidance of managing asthma attacks with dry powder, and so we still revert back to using salbutamol. We pervert the Salamol inhaler as being a lower carbon footprint in terms of the CO2 equivalent dose from this device compared to other salbutamol preparations, and we use this on a PRN basis in addition to the preventer inhaler, which is usually a dry powder device. If patients are not controlled with low-dose inhaled steroids, we then move to a MART regime, ideally using the Symbicort turbohaler 100/6. Now, the Symbicort turbohaler is licensed for use in this age group in the UK, but only as a fixed-dose combination treatment. It's not yet been licensed for MART, but we do have our National Institute of Clinical Excellence, and they have advised on asthma management, and they have suggested that it's a good idea to consider this treatment option in patients who are not controlled with other measures for their asthma treatment. So on that basis, we think we're justified in having that in there as a treatment option in this age group for patients who don't respond to regular inhaled steroids. So that's how we're changing practice in the UK at the moment. And this is how it's being presented for our local use in our region, in the south of England. We've got our peer website, which is available to everybody in the public domain. We have guidance which is age specific about diagnosis and treatment. Within the treatment sections, here's an example for the 12 plus. We've got 3 different discharge plans and action plans. The top one is for patients just using the Symbicort reliever treatment as required without any fixed dose daily treatment. And then we've got separate action plans for patients using MART regimes, either with a dry powder or with the Symbicort MDI, if they can't do that. And this is showing you an example of one of our action plans, which we're currently using in our locality. And what we've got here is similar to what I've shown you previously, some information about what MART is, some advice about maximum doses that can be used, an action plan around managing acute symptoms, some ideas about what represents good and poor control, when to seek help, some hyperlinks to inhaler devices, and a record of oral steroids to tell us if things are not going well. So this is some of the things that were happening in the UK to try to impact on our outcomes. I think they work. I've given you some idea as to why that might be the case. So the 2 important things, just to reiterate, is a decreased reliance on bronchodilator treatment. You can do that, I think, by using more PRN treatment rather than any kind of fixed dose combination, fixed dose uses of short-acting beta agonists. And you can get rid of short-acting beta agonists completely with a more effective MART regime using just one combination inhaler. You can't use salmeterol for this because it's got a long duration to onset of action. It may be a long-acting bronchodilator, but unlike formoterol, it takes much longer to be effective and so can't be used acutely in the same way for MART. Dry powder whenever possible, because dry powder is better for the environment. And finally, just want to plug the importance of delivering all this with a service that can also provide supportive care to patients and families, because asthma is a very stressful thing. Anxiety in families, either for other reasons or in relation to a child with recurrent acute wheezing, can of itself be an important factor that makes asthma worse and harder to manage. So interventions need to focus on measures which can help to decrease those anxieties, making asthma less severe and making those treatments more effective through the placebo benefits that also come through the belief in the effectiveness of what patients are doing to help themselves with good paediatric care to support them. So that's the end of my talk. My contact details are gary.connaught@uhs.nhs.uk. Please come back to me if you have any further questions or want clarity. This talk has been recorded on my YouTube website. If you go into Prof Gary Connaught, you should be able to find it there if you want to look at any of the slides in more detail and look at the references. I hope that was a useful talk, and I look forward to any questions you might have. Thank you. Goodbye.